depends on the patient, right? But again, I actually don't get that excited. So I'll actually, sometimes at first, I'll just make the patient do a sit to stand a few times. So that way it's not as specific to say, oh, squat and, what happens. I'll just say, can you sit down, have a seat, come on back up, right? And have a seat one more time and just stop halfway, right? I can get a sense of whether, are they actually able to flex? So they kind of doing one of these things, right? So that'll help start to differentiate. Is it really a sensitive hip? Or is it the fact that they actually just have very little hip flexion, right? So come on, stand back up. Can you just put your hands for me and just do like a little bow? And most of the time, depending on the patient, they don't have a hip hinge, right? So they're flexing. So then from there, you can just get them, just bend forward and touch your toes. Just get a sense of, just kind of screen out the back, right? Because you guys are screening out the back from a subjective question. And now what happens there and lean back, right? So again, what things would I be looking for in this particular case? What are you thinking? Yeah, but also, because remember too, is I'm not going to do a lumbar assessment on him, right? I'm not going to do my HMI test and all that stuff because he's coming for a hip. I just want to make sure that if he's talking about that right growing pain, that I didn't miss it because he's like, oh, that actually really hurts. But I also would have known if you take Jim's case, for example, I was golfing and this is what happened, I got anterior growing pain, I would actually be doing a lot of rotation and stuff like that to try to see. Some people have actually shown, so if you actually put your arms straight out and put your feet out just shoulder width apart and spin all the way around to the left. So some people would actually look and say, okay, how far can you go to the right and come back to the left? And what it is just sort of a visual thing for him. He looks stiff to me this way, right?
This, I'm good.
He must be hypermobile this way. So from that perspective, but one of the things that I actually want to see at times too is, so before I even get him to start doing single leg stands, I just want to see, can you just shift your weight to the left? Does that bother you? Shift your weight to the right. Okay. Stand on your right foot. And obviously for me there's a few things that I'll look at. Stand on your other side. Right? Is he just happy to be in this vicinity, right? So normally though I'm facing him, right? Because it's kind of creepy. But having an idea, and sometimes what I'll do too is I'll just actually move him around if they're comfortable with this to see proprioceptively if he's got control. Okay. Now, if you guys are doing, so if I was to do single leg stands with Erik again, what are you guys really looking for? Right? You're going to look for the hip drop and the glute med weakness and stuff. But ultimately, what's more important for you? So if I was to get you to face those guys, do a single leg stands, Erik, but just do a quarter squat. What's the first thing you're going to look for? Yeah, and what are you going to look at? Yeah, like whether he's going to drop and kind of go internally rotated. But sometimes actually people can actually fight that. How many of you guys actually look at what happens at the pelvis? Right? So remember, I'm not a big SI guy. Come on back up. So what I actually want to see, so turn around there for a second. So if you guys are doing the same thing, I actually pay more attention to what's going to happen right here. Because what's one of the things that's interesting with the hip? So I can move my femur from here up. So I'm moving my femur in my acetabulum, but I can also flex by doing this, right? So I just flexed my acetabulum on my femur. I just extended my hip, right? So that's actually what's really interesting when you're looking at someone who has some mild to moderate OA and they may actually have some impingement at the same time. So now go back into the same position here. And now I want to see if he actually even rotates even slightly at his pelvis. So he may not have that really good abductor drop, but if he's coming into this position, and you'll see a lot of them fight this, and their knee looks fine, and they're actually kind of actually tricking you a bit, but they've done this up top.
You're looking at pelvic torsion.
Exactly, right? So I would never go in and be like, I wouldn't palpate that. What I want to see functionally, right, for him, because remember, when I was even walking around, I couldn't walk very far, right? I was like, maybe 40 meters, and I'm walking in the park, and I got to sit down. Each step is what's actually happening, right? So I probably don't have good extension, all those things that Jim talked about, but these are those things that I just want to see, and then same thing as you say, okay, if I leave you there for a few seconds, is that going to reproduce your symptoms? And then he might also say, because remember, at first, they shouldn't have a ton of posterior pain, but if I leave him there long enough, he may start to see posterior pain. Now go back into that position, and if I just squish you as you go down, tell me what happens. Right? So I can also protect that from happening. So would I say that's a positive compression test? No. I just want to see what happens if I give him proprioceptive control. Okay?
So
then
when
yeah.
you're doing that, what is something where you go tick mark, that's good? And what are you meaning where you think there's something going on?
Yeah. So if I'm looking at him here, what I'll often look at is, can I lift you up? So just go into your right side and just do a little quarter squat. If I see that, that to me looks just fine. But I am looking at a couple of things. So he may do that and just come back. But the other thing I don't like about his movement here, he has no hip flexion, right? He just kind of stays. So if you go down into a little bit more of a hip hinge, can you guys see that now? Right? That's what I actually want to see there. And then now, and he's still good. But now go be a little bit weak on that side if you can. Right? So now he's dropped here. So automatically that's a positive test and I'm backing out. So there's no way, and this is what I see when I see a lot of patients, is they're actually, when they come to see me, I'm like, oh, how come physio didn't work? I don't know, I was doing these wall squats against the wall. There's no way he can do that exercise yet, right? But I'm also, if he's really strong here, I'm not necessarily going to give him an exercise of, side lie abduction because he clearly is strong in a weight-bearing position. He looks really good in that situation, okay? But you're also, especially for the really hypermobile patients, you'll see them actually collapse into their groin, right? So that you'll see the whole acetabulum just roll this way. Okay. Does that help? Okay. So have a seat there. So let's say
There is some merit with also having them sustain and hold that position, solely because, like, for instance, and Darryl doesn't know this, but I actually have like FAI on my right side. So even as holding that position, one of the things is I would mention to him is that I can start to feel that I was becoming fatigued, and I could feel more and more compression and pain come on slowly as I was trying to hold that.
Yeah, there's a lot of things too, and I think what's tricky is we kind of do our objective here and that's it, right? But oftentimes you can actually use some of your prescription or your exercise prescription to be an ongoing component of assessment. So if I knew that he had sort of that impingement on that side, typically a lot of people with impingement in OA, so they get a lot of cramping if you're in those end ranges. So if you actually were to have them, and let's say I was worried about flexion or something like that, I could have them like with a slow draw. If I put let's say I put a little sponge or something underneath me and I had Erik keep doing that on his right side, 100% he's going to cramp, right? And then if I want to know if I've improved him, if I've improved his through his rehab process, I get him to do that again in like 6 weeks and I have an idea if he's gotten better. So we'll work on all those little strategies tomorrow. But if you just pinch that between your knees, so in theory, he should not like me if he has a really bad impingement, okay? So just keep your knees, yep. And now keep pinch this together, but separate your ankles. So if you were to look at that and drop kind of a pseudo plumb line down, does Erik actually does he look like he has a restriction on his right versus his left? It's cramping, right? Mm-hmm. But he's cramping though, right? So now one of the things that's interesting is if I really wanted to be mean to him, I would actually bring his knees up a little bit, and he does. But I won't.
Come on, let's do it.
No, it'll be mean. So just pinch that again. One of the things that I would often do though is, okay. Right? Now what I want to do is actually just sit on your hands for me and actually just kind of lift up on your ischial tuberosity. And now separate your knees or your ankles. Does that take away your cramp at all?
A little bit, yes.
Yeah. And all I did is just reduce his hip flexion.
Funny now he's actually displaying.
Yeah. The other thing too for him, and he's smart, that's the problem. So most of your patients won't know, but what you'll find is they'll be just screaming with eversion, right? Because it's same with our hip away patients. They just don't have any rotation. So instead of worrying about dropping the plumb line, I'm like, why is your foot way over there? And they're like, oh, I didn't even notice that. And then they start to pick up that they don't have that rotation. Okay. One of the things though to be careful with, there's a few guys that have taught me this over the years, is that if that's a painful position, this used to be the first exercise we learned on a course. So if I know I'm going to cramp Erik, if I actually don't like Erik, the best thing for me to do is just give him a TheraBand and tell him to do this 3 times a day for 20 reps. I'll never see him again. Guaranteed, right? Because should I not give him that exercise? Eventually I'm going to have to, but I can't give him to that day one because I just literally and he's probably going to be sore just from doing that, okay? Because remember, if he's got some impingement, I probably, and I don't know anything about his hip yet, but I probably just literally gouged inside of his labrum too, right? So one of the things to look at is again, you'll see this in some assessments that people will do, is just getting a sense of what happens when I get to his end range here, right? And the reason I start here as opposed to supine is because I just want to see what he's even willing to do, right? Oh, bad knee.
Yeah, I've had 2 surgeries on my right and 1 on my left.
So if again, just looking at where he's at, and sometimes what I'll do is I'll even ask him, just draw, bring the back of your heel and bring it up as far up your leg as you can, just to see what he's willing to do. Do it on the other side. Right? So again, I'm just trying to figure out too, if depending on what type of, into big patient he is, I want to know, am I going to go in there and crank on his favor or am I not? Right? So this already tells me this doesn't look good. Okay. So from here, one of the things though that I often would like to look at is I can actually assess internal and external rotation here, right? So what I'm going to do is I'm going to ask Erik, okay, I'm not going to, some people will tell you should keep the pen there, but there's no way he's not going to like it. So hold that there for me, Erik. Don't let me move that leg. So I'm actually getting him to now assess, right? Do I think that this is relevant? I'm not doing it because I don't need to do it because he can stand on one foot. Okay, push out for me, and there's his external rotation. Now again, he should be strong here because he's a healthy guy, so I'm not really going to weigh the pros and cons. But again, I'm not going to say his problem is because he's weak there. But you guys, if you're doing this on a regular basis, absolutely you'll pick up some weakness here, no problem. Okay, any other thoughts there? Anything to add, Jim? Okay. So what did you notice, though, so far from that? Like just Erik's movement pattern, right? Is he doesn't like to hip hinge. He certainly doesn't like to go into external rotation, and I can cramp him on flexion, internal rotation. If he didn't tell me, and this is hard now because now that I know that he's got impingement on this side, I would suggest that there's something going on into this hip because his other side is fine. But I bet you, based on some of the studies, he's got to have some sort of impingement or something, or some OA changes eventually onto that left side, because it's just how mom and dad probably made him.